So let's finish out this series by talking about treatments for stroke and nursing priorities overall. So there's been a variety of PowerPoints that break down the different system and nursing interventions for both of those, but let's just kind of look at this as a whole at some of the big things, especially in that acute period of the stroke that I'm going to need to do as the nurse. So let's talk about the ischemic stroke treatment. If you watched my first PowerPoint about this in general, I talked about a medication called TPA. And what TPA is, it's different than other medications we talked about. It's the only one in its class that's what's called a clot buster. So when we talked about anticoagulation, we talked about how anticoagulation can prevent you from forming new clots, but it cannot break down clots that are already there. TPA is the only medication that can actually break down clots that are already there. It's stronger than anticoagulation, so we're going to be a higher risk for bleeding, and I'm going to really need to protect for this patient's safety. So we talked about the fact that one of my most important questions that I need to ask when that patient first comes in the door and looks like they're having a stroke is, when did their symptoms start? And so per your book, and again, every hospital is a little different, but usually the range we're looking for is about within 3 to 4.5 hours. If it's been longer than 4.5 hours since their symptoms started, the risk of giving them TPA is going to be too great. Whereas if it's in that window, that 3 to 4.5 hours, and keep in mind, like, I mean, if it's been an hour, that's fine too. Anything, less than 4.5 hours. It doesn't have to, I should say, when it says within 3 to 4.5 hours, I guess what I mean is that like, that's one of the best windows to do it. But obviously if it was like it happened 30 minutes ago, they can still get TPA, but we just don't want it to be too long since their first symptom, if that makes sense. So if it's been longer than 4.5 hours, it's too much of a risk to give that. But if it's less than 4.5 hours, then it's a treatment that's going to be available for them. The patient has to meet criteria. So every hospital, again, might have a little bit different things, but some of the criteria might be like recent surgeries, open wounds, anything that would put them at risk for bleeding, if they've had a previous hemorrhagic stroke, what their blood pressure is, things like that can put them at risk where they might not be able to receive TPA. So we'll just go through our hospital's checklist and make sure that the patient is appropriate for that treatment. And then some of the first actions that I need to take, I need to rule out that they're not having, because if they come in with stroke symptoms, let's say someone comes in, they have facial slurred speech, one-sided weakness, it looks like they're having a stroke. I don't know if they're having a stroke because they have a blood clot in their brain, or if they're having a stroke because they're having bleeding in their brain. And I cannot give TPA if they're bleeding. So I'm going to go to CAT scan and get a CT of their head to make sure there's no bleeding. If there's no bleeding, then they could receive TPA. But if there's bleeding, that's not going to be appropriate. And we're going to talk about treatment for hemorrhagic strokes on a different slide. We also need to rule out hypoglycemia, because some of the symptoms of stroke can also look a lot like hypoglycemia. And so I want to check a blood glucose to make sure that they are within normal range, to make sure that there's not, like, I think it's a stroke, but it's actually just low blood glucose. That low blood glucose gets you every time, because there's so many things that can look like hypoglycemia and things like that. So you always want to differentiate that cause. And then we talked about in the other PowerPoint about checking coagulation levels and making sure that they don't already have like a high risk of bleeding, because this is going to make them bleed a lot more, or be at higher risk to bleed. We need to have good IV access. So before we start the TPA, it's not that the TPA has to have a great IV or anything like that. It should, but the big thing is that I don't want to stick this person for 24 hours after I give the TPA, because they're going to be such a high risk. They're not going to stop bleeding. And so I want to get very good IV access so that I don't have to stick them after I start the TPA. The patient's going to be at bed rest on bed rest while they receive the TPA, and then for 24 hours afterward to prevent them. If they fall, they're again not going to stop bleeding. And then I need to do regular neurological assessments. We do these a lot. Like I'm talking about when I say frequently, like, we start out like with every 15 minutes, and we do that for a long period of time. Then we do every 30 minutes. And then we do every hour for like 12 hours. So like, we do very, very frequent checks on these patients, because we want to see whether it's working or not. Are they getting better, or are they not? So we'll talk about that later. We can also do what's called a thrombectomy, which is that go in. Remember cardiac cath lab. We can also go in and go into the IR, interventional radiology. And what we can do is we can go up into the blood vessels in the brain and see what's going on. And we can actually retrieve or take that clot out if there's a clot blocking. And if they don't, if for some reason they don't meet the criteria for TPA or thrombectomy, then we can also just support perfusion and manage their deficits and symptoms. So, on the other hand, hemorrhagic stroke treatment, we want to prevent further bleeding or trauma to the brain. So, some of my big goals is to manage their blood pressure. I do not want their blood pressure being too high. They already have all this pressure in their brain. Sorry, all this problems in their brain where they're not getting blood flow. And then if their blood pressure is high and they're bleeding, that's going to cause them to bleed even more. So I don't want their blood pressure to be low. I want them to get blood flow to the brain, but I don't want it to be too high. So I'm going to manage their hypertension. My doctor's going to give me a range. I'm going to want to stay in between that range. I also want to prevent fall or injury. So safety is going to be a big priority for this patient. There's some options I can do. I can get rid of the blood or fix the cause of the bleeding. So I can get rid of, if there's just bleeding there, I can, they can go in and, not me, but someone can go in and literally evacuate or take the blood out of their brain. If they have an aneurysm, we can clip it or coil it so that that bleeding from that aneurysm stops. And I can also give them medications to prevent vasospasm, like that nimodipine, which is the calcium channel blocker. Cardiac meds again, yay, it's everywhere. And so that can also help to fix that bleeding if they have that going on. This patient will not qualify for TPA. So if they have a hemorrhagic stroke, they will not be receiving TPA. They should not. They're already bleeding. Giving them TPA is pretty much like opening the floodgates for them to bleed out. So definitely a lot of these patients that we just kind of monitor them and try to support them. So collaborative care options for stroke, it's so important. These patients are affected mind, body, soul, and spirit. So we want to help them on all levels to see what we can do to support them, along the way, as they're recovering. Because recovery for a stroke is measured in months to years, not days to weeks. And so physical therapy to get their physical strength, like occupational therapy to learn how to take care of themselves and, use adaptive devices at home, speech therapy to help with their speech deficits, communication tools like, communication boards and adaptive devices to help me communicate with them. Adaptive devices like things to help them to be able to feed themselves, dress themselves, things like that are going to make their day-to-day and self-care more possible. Goes kind of along with self-care devices as well. And then psychological and therapy and rehabilitative process. Like these patients usually need to go to stroke rehab, and they're going to need a lot of outpatient therapy for their stroke. So my role as the nurse for a patient that's had a stroke is pretty much preventing and monitoring the treatment complications. Because like I mentioned with the TPA, I need to be watching. If a patient has a blood clot in their brain, they qualify for TPA, I give them the TPA. But my biggest concern then is going to be that they're going to bleed. What if this patient starts bleeding? We have a lot of patients, what happens is they come in with a stroke that's a blood clot. So they need TPA. We give them the TPA, and then what happens is they start bleeding, and they actually end up having a hemorrhagic stroke after their ischemic stroke. So I have to watch really closely and make sure that they are not having any signs of we call it bleeding after getting that medication. So that's why one of the things that I want to look for is if they, if they came in with a blood clot in their brain and then I gave them TPA, what I'm going to look for is that if they're having another stroke, then their mental status is going to change. So if I'm giving a patient TPA and they're starting to do better, like they're starting to improve in some of their symptoms, their weakness is getting better, maybe they're able to communicate or talk, but then all of a sudden they start going downhill, that's usually a sign that they may be bleeding in their brain or having another stroke. And so I really want to be watching for any signs of bleeding. And when you're bleeding inside, remember a lot of times those changes happen in your blood pressure. And then if it's in your brain, it's going to be in your mental status. So we always want to look at level of consciousness or those changes. And that's why I have to do really frequent neurological assessments. I want to support brain perfusion, and I'm going to do that. We talk in class a little bit about ICP or intracranial pressure. And what I want to do is I want to support it from not getting too high. I don't want their ICP to get too high. So I'm going to sit their head of bed up, keep their head kind of neutral so it's not turned, so that they can get good blood flow from their necks up to their neck Now, hopefully they don't have more than one, their neck up to their brain. And then I'm also going to support them in not like a quiet environment, not too much stimulation. If they have a fever, I want to manage that. Anything that's going to make their brain have to work harder, I want to avoid that. Kind of think about like how we heart failure patients, we try to like kind of manage everything for them so their heart doesn't have to work so hard. I don't want the brain to work so hard. So I want to decrease stimulation, quiet environment, dark, let them sleep, not a lot of interactions and bothering them all the time, and try to what do you call it, give them time to rest. So then I also want to support their nutrition. A lot of these patients are going to have issues with swallowing, eating, and generally getting the nutrients they need. And they're definitely going to need that because this is a long rehabilitative process. I'm going to support their mobility. If they want to get up, move around, if it's safe for them to do, I want to encourage them to do that, and going kind of along with that self-care, let them do things for themselves, take care of themselves, and do as much as they can to manage their day-to-day life in a safe level. It's my job to kind of help them to find that balance between asking for help when needed, but also doing what they can for themselves. Therapeutic communication and just supporting communication. These patients can get really frustrated. A lot of them have speech and communication issues. So just being there for them and letting them know that they can communicate with me and that I'm there to support them. And then also being very patient with them, because a lot of times it takes them longer to communicate or get things done. So I just need to be there for them and meet them where they're at. I'm going to protect for safety because some of these patients are going to be impulsive. And then even the patients that are not impulsive, they are going to have weakness. So they're going to be high risk for falls and injury. And then teaching for the family is going to be key because their family is going to be at home with them during this long process and need a lot of support themselves and to know which direction and how to help their family member. So once patients go home, they're going to be put on certain medications, and these are going to be medications to prevent further strokes and then also to prevent injuries, or other like issues from the stroke. And so first, we want to give them medications to manage their blood pressure. A lot of strokes happen because of too much pressure or hypertension. So a lot of these patients, or most of them, are going to be discharged on antihypertensive medications. We're also going to give them medications to manage outside conditions that can lead to a stroke. So if they have atrial fibrillation, they're going to be on anticoagulation. Every patient who's had a stroke is not going to be on anticoagulation. So a lot of times I'll see students say like, oh yeah, this patient is on anticoagulation because they had a stroke. But they're usually not on anticoagulation because they had a stroke. They're on anticoagulation because they have AFib, which can lead to another stroke. So that's kind of why they're on that. There's also medications to prevent plaque buildup, like cholesterol medications, like statins, cardiac meds again. And then the big thing that all patients with strokes are put on is antiplatelets. So medications that make it hard for them to make clots. So aspirin or clopidogrel, or sometimes both, patients are put on to help them to prevent them from having another stroke. And so as a whole, that's kind of the basic treatment, my goals, my priorities, where I'm trying to help this patient. You can see it takes helping them head to toe. These patients have a lot of issues, very complex care, which is why I've broken this up into a variety of PowerPoints to kind of break down some of those issues a little bit more in depth. But I hope this kind of gives you an idea of how you're going to be taking care of these stroke patients. And I know you're going to do a great job. See you next time.